So nice to meet everybody. My name is Dr. Archana Gupta. I'm a family physician, and I am the chair of the Global Health Member Interest Group at the College of Family Physicians of Canada. And I would like for my vice chair to also introduce herself.
Hi, everyone. I'm sorry. So I'm Dr. Catherine G. I'm a family physician in Toronto, and I'm the vice chair of the Global Health Member Interest Group.
Thank you, Catherine. So we are so excited to be bringing you this seminar today, the impact of COVID-19 on prison populations across Canada. This is the third webinar in a series of three, focusing on how the pandemic has affected marginalized populations nationally. This seminar and this web series is brought to you by the Global Health Member Interest Group at the college. And we, if anybody is not already a member, we encourage you to join this group. It is also a joint session being put on through the Prison Health Member Interest Group. Next slide, please. Before we begin, I'm going to take this opportunity to acknowledge the traditional land that we are all on. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The CFPC recognizes that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The CFPC respects that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all attendees to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. As this session is accredited for main core credits, we are going to just quickly go through our declaration of conflicts of interest. We have many great faculty and presenters for you today. Our moderator, Dr. Claire Bodkin, has received some research grants from CRHR and CRISM. One of our faculty speakers, Dr. Catherine Tong, has received honoraria from the OCFP, Conference Scientific Planning Committee. And our other, next slide, please. And our other speakers, Dr. Keith Courtney, and Miss Mo Korchinski and Dr. Nader Sharifi have no relationships with financial sponsors. Next slide, please. This program has received financial support from the College of Family Physicians of Canada through a member interest group section project grant. And this program has received in-kind support from the College of Family Physicians of Canada. And there's no potential conflicts of interest and no potential biases. Next slide, please. Just a few housekeeping issues. Once again, this seminar is accredited for 1 credit per hour. You will be emailed an evaluation after the session today, and once it is completed, you will receive a certificate of attendance. We welcome questions for this seminar. We invite you to use the question and answer feature at the bottom of the Zoom, and we will try to integrate that into the questions with panelists throughout the session. And now, without further ado, I am so pleased to invite our moderator for the evening, Dr. Claire Bodkin, who is our chair of the Prison Health Member Interest Group at the college, to introduce herself and to take over.
Thanks so much for organizing this and for, setting this up. It's really exciting to be here having this conversation. And I'm excited to see some familiar names on the attendee list, as well as some new folks that I haven't met before. And in particular, our new vice chair of the Prison Health Member Interest Group, Dr. Nushin Niku, is on the line as well. So shout out to her for joining the interest group. So yeah, we're going to dive right in. So can we go to the next slide, please? So just wanted to start by setting the context a little bit before we introduce the panelists and get into the discussion. So in Canada, there are about 233,000 adult admissions a year, and the vast majority of these are in the provincial and territorial system. So important to recognize that if you're serving a sentence of 2 years or longer, you're in a federal institution operated by Correctional Services Canada. If you're on remand awaiting trial, so you have been charged, but you are not convicted, then you're held in a provincial or territorial facility. Or if you're serving a sentence that's 2 years less a day, you're in a provincial facility. And that's where the vast majority of admissions are happening in Canada. There's over 14,000 youth admissions a year, and actually it would be more than this because we don't have accurate data from a number of provinces. And then our prison system also houses people who are detained in migrant detention, so immigration detention. And there's over 8,000 folks in immigration detention a year. 2/3 of people who are detained in Canada will be held for less than a month. So these are folks that are often moving in and out of community and then institutional and incarcerated settings rather quickly. And on any given day, there's about 38,500 people who are detained somewhere in Canada. Next slide, please. So in terms of how healthcare is delivered, it depends on which prison system we're talking about. So federally, it's the Correctional Services of Canada that's delivering healthcare. So it is not the Ministry of Health at the federal level that oversees the delivery and administration of healthcare in prison. And then provincially, there is a mixed bag. So right now in BC, Alberta, and Nova Scotia, the health ministries are responsible for healthcare delivered in corrections. There's been a partial transfer in Quebec, so outside of the major urban centers. So in Montreal and Quebec City, it's delivered by the Ministry of Corrections, and then outside of that, it's delivered by the Ministries of Health. There is right now the province of New Brunswick is undergoing a process of transferring, but that has not been completed yet. And then other provinces are under provincial ministries of safety and correctional services. So for example, in Ontario, where I practice, it's the Ministry of Corrections that oversees healthcare in prison. So the numbers, when you look at how many people are incarcerated in different places, about 75% of the population is receiving healthcare that is delivered by corrections and not by ministries of health. Next slide. Sorry, this slide didn't translate very well. In the middle is the classic EPI triangle. And so you've got host, environment, and agent. So we know that in prisons, the agent is the same. So we've got the COVID-19 virus, but the host and the environment are quite different. So from a host perspective, we have a population where the structural determinants of health are overlapping with the structural determinants of incarceration. So things like colonization, anti-Black racism, poverty, these are all things that determine who is incarcerated and also affect poor health outcomes. And then in terms of the environment, these are crowded congregate settings. Oftentimes, there are more people housed in a facility than it was initially built to house. And even if it's the sort of appropriate number or less than that, it's still a congregate setting. So often, eating meals together, sharing shower facilities, recreational spaces, that kind of thing. And so that contributes to a disproportionate impact of COVID in prisons. Next slide. So before the variants of concern in wave 1, from March to May 2020, about 3% of people who were incarcerated federally had COVID, and this was compared to 0.2% of the general Canadian population. So I don't have updated numbers that look at this same question for incarcerated populations with the more recent waves. But suspect that it's similar in that we're seeing large outbreaks in correctional facilities and that there's some data to suggest that the incidence and prevalence is much higher in those settings and populations. And so there's been outbreaks at a number of different prisons across the country. And many of these have been very large outbreaks. So, sometimes an outbreak is declared when there's only 2 people affected, but as you can see here, 136 cases in one facility, 60 cases in another facility. So these are very large outbreaks that have been happening. And hopefully that just sets the stage for us to get into our discussion. So I want to introduce all of our panelists. Actually, this is a bit sneaky of me as a moderator. I'm going to get them to introduce themselves. So I'll ask Dr. Catherine Tong if you could go first and just introduce yourself.
Sure. Thank you, Claire. I'm Catherine Tong. I am the institutional physician at the Grand Valley Institute for Women in Kitchener-Waterloo. It is the biggest women's correctional facility at the federal level. We have currently about 177 inmates at our facility at the moment.
Thanks, Dr. Tong. And then I'll ask Mo Korchinski if you could introduce yourself.
Hi, everybody. My name is Mo Korchinski, and I'm the Executive Director of Unlocking the Gate Service Society. I'm located in British Columbia. I run a peer mentor program. I work with all prisons in BC, provincial and federal, where we connect with people before they get released, and we support them the day they get released. So I'm glad to be here.
And then Dr. Keith Courtney, I'll get you to introduce yourself.
I am Keith Courtney. I am a forensic psychiatrist by training. I'm the facilities medical director for the 10 provincial correctional facilities in Alberta. We have a total of about 3,600 inmates. We have one of the largest jails in the country, Edmonton Remand Center, which can house up to 1,500 inmates, down to our smallest facilities, which are 2 youth facilities that currently have about between 30 and 50 youth in each facility.
And then Dr. Sharifi, can you introduce yourself?
Yes, hi everybody, thank you. My name's Nader Sharifi, and I've been a family physician for over 20 years, working in prison and correctional medicine. Most recently, I was the medical director for Correctional Health Services, which is the health authority wing that was overseeing healthcare in the provincial jails in British Columbia. And currently I work at the Pacific Institution and Regional Treatment Center, which is a federal facility in Abbotsford. And I'm also the National Opioid Agonist Treatment Advisor for CSC. Thank you for having me.
So thanks to everyone for taking the time to join us today, both the panelists and the attendees, and really looking forward to a great conversation about how COVID has affected people who are incarcerated in Canada. On that note, we'll start with some questions around what we call meso issues. So we're breaking it up today into meso issues, macro issues, and micro issues. So I was hoping that first Catherine and then Keith, you could tell us a little bit about how your institution has experienced and responded to the COVID-19 pandemic. So Catherine, I'll turn it over to you.
Sure, thank you for that question. So as Claire, you have mentioned in the intro slides that the inmates who are at a federal correctional facility are serving a longer sentence. So our population serves anywhere between months to years to decades of their sentence at the institution. So that means that a lot of them actually participate in longitudinal educational programs, skill development programs, and some are actually gainfully employed in the community or in the institution, depending on their security level. So as you can imagine, when COVID-19 arrived in the region, similarly to patients in our community, our inmates also experienced, a fairly significant reduction in their enrichment programs and their employment. For example, if their employment is not considered an essential employment, then they would lose access to that. Of course, there's going to be less movement and less visiting program coordinating, less events. Their contact with each other is also disrupted as well. Folks are I'm sure this happens in other institutions as well, grouped into cohorts so that there's no mixing in between of smaller groups. To reduce the chance of disastrous transmission. We, of course, still get a fair bit of movement coming into the institution as admissions, and we also release inmates as usual, but that's hampered by the isolation protocols that's made necessary by COVID. So there's quite a bit of isolation, like literal isolation when patients come into the institution for a number of days, and you can imagine what that would kind of do to their adjustment period and their experience coming into a new environment. And in addition to that, there's also quite a bit of change in the healthcare access as well, which I think we'll get into in a little bit. So all is to say that similarly to the patients in the community, COVID has really affected federal inmates' access to program services and their entire experience as incarcerated person, as well as their interaction socially in general. So one can imagine that in addition to being already experiencing, incarceration, this is very stressful and profound.
Yeah, I can echo some of that. In some ways, there's not that big a difference between the federal facilities and provincial facilities. I think there is one remarkable difference: is our length of stay that creates such a nightmare. We quoted earlier that the length of stay, the mean length of stay in a remand center, which is pre-sentencing, is about 2 to 4 weeks, but the mode is a couple of days. Mode are people like you and I who get picked up with a DUI, and end up in jail for a couple of days, and then we can pay bail and get out, or we're like on our own reconnaissance. So that creates a tremendous difficulty in keeping the virus under control. We've had to set up very secure isolation procedures, quarantine procedures when folks come in. The problem with that is you've already got a very fragile population in terms of mental health. You've got a population who is withdrawing from predominantly opiates, but crystal meth, so increased risk of aggression, violence, increased risk of suicide. So that had to go into place very quickly. So that length of stay, it factors tremendously into almost all of our planning. They come in quickly, but then we also leave quickly. So everyone who comes in the door gets tested. And I'm lucky enough to work under Alberta Health Services, so it's one health authority that oversees it. So we have really quick access to the MOHs, to infection control, and to tracing, contact tracing. However, when you're there a matter of less than 24 hours and you're out, and then it turns out you're COVID positive, we don't know if you're going to a shelter. We don't know if you're going back, what we call living rough, living on the streets, or back to housing. It's created quite a tracing nightmare for us as well. And then I think, like Catherine was saying, there's the isolation factor, but you're also, you're kind of at risk of infection. And what I mean, and it's at the whim of whoever walks in the door, right? We have a significant number of folks who are anti-maskers and don't believe in masking. And we've been able to trace all of our contacts so far, I think without exception, all of our outbreaks, without exception, to staff. So it's interesting, we're doing a really good job in maintaining or at assessing inmates as they come in the door, and or incarcerated individuals as they come in the door. But we're still at the whim of people who choose not to mask, and that's where we keep having continual outbreaks. We had an outbreak that started today at Women's Facility, and what can be one person on day one can be 45 on day two.
Thanks for that. And Keith, I noticed you said inmate and then you quickly said incarcerated person. So thanks for that reminder for like the language that we're using as well. I really appreciate that. And I hear, like such a loss of people's, routines and support services and employment programs, and also just how hard, like already there's the difficulty of the loss of autonomy that people have when they come into prison, and how that means that, you know, the typical public health advice that's offered is very difficult or impossible to follow with that loss of autonomy. And you're just sort of exposed to whoever you're exposed to when you're in a prison. Okay, so now to chat a little bit more about how healthcare specifically has changed in light of the pandemic. And Catherine, again, if you can sort of speak to some of the changes you've seen at the federal level, that would be great. And then
Yeah, sure.
I won't introduce everyone. So it'll be Catherine and then Keith and then Mo. I'll get you to take that on. Okay.
Sure. So I can speak on the reality at Grand Valley Institute for Women. The health services there is very much like typical community-based family practice because the longer time that we have with the patients there. So as the family physician there, in a relatively smaller inmate population, we do rely normally quite a bit on the community acute care hospitals, the community consulting services as our support, as my referral resources. So as you can imagine, in the community, a lot of the healthcare turned very quickly into virtual care. And the same thing had happened at our institution as well. So in some ways, a lot of the more elective kind of procedures, things that are booked are delayed or, you know, on hold. Whereas when things can be done through virtual care, we do actually experience fairly good access because of that infrastructure being available through OTN. So we're very thankful for that resource to be available. So it's kind of balanced out in a way. When our patients do need to go out to access emergency departments, or if they are in a situation where they require admission to an acute care hospital, unfortunately, then it becomes quite a bit of a challenge during the pandemic, where our patients would require some escorts depending on their level of security. There might be 1 or 2 officers that's attending any kind of appointments or admissions throughout their entire stay in the hospital with the inmates. So unfortunately, that does trigger, you know, some concerns from infectious prevention and control teams at the acute care hospital. So this is where our team and the acute care hospital team would have to communicate on a regular basis and make sure that we're doing everything we can to reduce the potential exposure of the number of people involved and make sure that our patients are well looked after without jeopardizing, you know, the public health measures that's implemented by the hospital. We did experience major difficulties with accessing normal visiting programs in terms of ancillary investigations. So normally we have a regular ultrasound, visiting service, x-rays. Unfortunately, during many months of the pandemic, we had some difficulties with accessing that, in addition to dental, optometry, physiotherapy. So all the regular, you know, cachet of services had unfortunately been fairly badly interrupted due to the visiting issues and concerns about transmission. So I'm happy to report that things are getting back on track. We did have to send people out to outpatient investigations in the community for the urgent ones, but we are having our visiting services come back in the last little while. Even myself, I was on virtual care for a month or 2 in the middle of the pandemic prior to everyone being immunized at that time. So because I had to also work in a different healthcare environment, and that was considered a risk to the vulnerable population within the institution. So I I'm not a big fan personally of providing virtual care, but I'm again grateful for the option of being able to do that sometimes.
Thanks for that, Dr. Tong. Dr. Courtney, do you have anything to add on top of that?
Yeah, just a couple of quick things with it. I mean, there's not that big a difference in similarity. One of the things that really affect, we had a massive increase in virtual care, as you might guess, and some of that we had to take a look at our staff, particularly our corrections healthcare providers, because many of them are not young, which put them at higher risk. I have a significant number of folk over 65, and so with illnesses, so they were not able to go in. So setting up virtual care became a huge issue for us. And then communication between us and the feds, it's become excellent. That's one. If there's anything that's a positive of COVID, that might be one of them. Because with the federal system, because we communicate weekly, sometimes daily, about our transfers back and forth, who may be positive, who may be coming. And there are certain things that are not going to go backwards. I'd like to see some of the virtual care, the consulting stay. I think it's great that I can access a hepatologist, this afternoon if I need to, right? I think one of the interesting things that's happened is as soon as this came along and we had all these dialogues, our jails kind of emptied out. They went down in some cases by close to half of the population. And I find it interesting that we were able to accommodate during that time with things like house arrest and other community ways of measuring it. But now that COVID is starting to lifting, it's coming back up again. I have to question if it was okay then, and we did okay. Why are the jail? It's just more of a political, not a healthcare strategy. Why is it slowly starting to raise again?
Mm-hmm.
I think the other thing that's really affected us is we haven't just had inmate outbreaks, we've had staff outbreaks, and that's been huge because all of a sudden, we had a facility where 6 or 7 staff of our staff nurses were out at the same time. We're lucky again because we're able to borrow from other facilities because we're under the Health Care Authority. But that's not easy to do because they were all hurting as well.
Yeah. And I appreciate your point. I mean, I think there's a much broader debate to have around what's healthcare and what's political, but certainly if we think of incarceration as a determinant of health, then it is worth thinking about, does anyone need to be incarcerated, but especially like how many people really need to be incarcerated and what are the lessons to learn from the early stage of the pandemic. So, and the decarceration efforts. So thanks for bringing that up. Mo, over to you.
I'll just follow right into what you were just saying about, the numbers inside the prison system. So we had mass releasing here in BC in March, and also our overdose crisis numbers went through the roof, and they still are, right? Again, as somebody, I have lived experience. I spent many years in addiction, about 18 years and 8 years inside the prison system. And I'm telling you, jail saves our lives. It takes us out of that detox, and takes us somewhere where we can have a break from the drugs, get to, clean. And, I'd love to look at the numbers of everybody who's, the 160, 180, the 200, a month that are dying in BC. How many should have been incarcerated? Would have, right? So as somebody who, lots of people say we shouldn't have prisons, but for me, I wouldn't be sitting here today if it wasn't for the prison system, right? It gave me an opportunity to heal, get out of that lifestyle and face my issues. And BC, all I can do is put my hands up to BC Corrections here and the healthcare system. In the beginning of this, they were amazing. I'm like Alberta. I really hope a lot of things stay. A lot of issues came above, and I think BC Corrections has stepped up. Our prisons are all over the place. Women, we only have one provincial prison in BC, so people come from all over. We have Zoom visits now, so people can all have visits. So there's a lot of really good things that have come out of COVID. my programs, we continued working right through COVID. We were one of the few only organizations that continued working. There was no bus services, no airports, no nothing. We were picking people up and making sure people got home safe. Healthcare was great. We made sure people had COVID checks, COVID tested before my staff went and picked them up. So it became a really good partnership, which really strengthened our relationship with BC Corrections. And so, yeah, I think there's a lot can get out of COVID. You know, I just hope a lot of things stay the same once this is over. So, thanks.
Thanks so much for that, Mo. I'm feeling the stress of being the moderator, and we're already halfway through our time, and we've only gone through like our first 2 questions. So I will just ask all of the panelists to like share your wisdom, and we may need to cut a couple of questions and be mindful of time. On that note, and Mo, you really you already alluded to this, but so people who use drugs are experiencing overlapping pandemics right now. So the COVID-19 pandemic and then the opioid poisoning and overdose death pandemic. So Dr. Sharifi, if you could share a little bit about how this has affected people in prison, that would be great. And Mo, if you have anything to add about it after Nader, that would be great as well.
Thank you for the question, Claire. So this is really heart-wrenching what is happening with the opioid overdose epidemic. And it was declared in BC in 2016 with Perry Kendall, our public health officer at the time. So when the health authority took over the healthcare in BC Corrections in 2017, we were able to get additional funding to have designated opioid agonist treatment nurses at all of the BC correction sites, and shortly after that, we were able to get funding to have community transition teams, and these are teams that have a peer support worker and a social worker that actually are based in the community to help and assist the clients that are being released from custody and are on opioid agonist treatment, so that there's no gap in their prescription for their medication. So and that sort of mimics a lot of what Mo has done with Unlocking the Gates, which is fabulous, a fabulous program. So those were already in place, but as Mo and Keith mentioned, with the onset of the pandemic, the COVID-19 pandemic, there was a significant drop in custody, so that the centers could create social sort of distancing and minimize the risk of transmission. And conversely, we saw a rapid increase in opioid overdoses and opioid overdose deaths. So BC at that time implemented risk mitigation prescribing or pandemic prescribing to allow sort of easier prescription of opioid agonist treatment and supporting medications to bridge people during this gap. Within custody, intake continues to be a high-risk time for opioid overdose, and as we all know, shortly after release from custody continues to be a high-risk sort of time. And I don't think that has we don't necessarily have details on the release yet. There's a time lag from the coroner service, but on intake, we did see a slight increase in the number of overdoses during the pandemic.
Thanks, Nader. Mo, do you have anything you want to add about that?
No, I just think for my team, so like everybody who works on my team all has prison experience and addiction. So, you know, when COVID hit, or how did COVID, you know, affect your organization? It's not. It's the opiate crisis. It's the biggest. You know, some of my staff have lost children. So it's affected us personally as well. And I'll tell you, I probably know over 500 people that are no longer with us. So it affects us every day. So that's our number one, is the opiate crisis. Right, you know, making sure whoever's getting released from prison has somewhere safe to go, and that's the problem. We don't have any, you know, lack of housing, lack of safe places, especially with COVID restrictions. You know, shelters are at, you know, quarter of the beds. A lot of people want people COVID tested before they go to treatment. So there's a lot of barriers for people coming out of prison, more than usual. We have enough as it is, and COVID's just added more barriers. So,
can I add real quickly also, Claire? To what you guys have just said, Interestingly for us, because of the quarantine and the isolation, when people come in, we're catching more overdoses quicker because they're checked on, people are checked on every day. And some of these folks would normally just go to the unit and we wouldn't see them until they were in crisis. It's the folks that come in and we know they're addicted and then they're gone the next day and we don't know where they're gone. So our overdoses in corrections have gone down, within the wall have gone down, but in the community, we've seen them go up. And so going back, over the years, I've had lots of inmates tell me that jail has saved their lives. Yeah.
So this sort of ties into that, knowing that the issues for folks who are incarcerated are not just while they're in prison, but actually it's when they're leaving prison. That is one of the big risk periods and challenging times. Mo, can you just speak a little bit about how COVID-19 is affecting people when they actually leave prison?
Yeah, I mean, for a lot of it is not how do where do people go, right? Again, we have so high population, what are homeless. I think from one of our research studies, 85% people coming out of our provincial prison are homeless upon release, right? They have jail clothes, they have flip-flops, they have, not the proper clothes because there's no secondhand stores what are, taking donations. So there's a lot, people need food, clothing, shelter the day they get released, not a month or 2 months down the road. And that's where our organization comes on to making sure people aren't homeless or on the house. They have take-home kits, so everybody's trained, everybody has take-home, everybody has clean supplies. Like we work with clients no matter if they're going to stay clean or if they're going to go back out and use. Number one is making sure people stay alive. That is our model, so whatever it takes. But again, with everything shut down and, lack of places, to me, giving somebody a tent kit is not an answer for somebody being released from prison. Right. And that's big here in BC because we don't have anywhere for people to go. So, right. So it's a challenge. I mean, last year, I think we had 500 clients and we housed over 200. So that's good. But we definitely, I'd like to see, more people having housing and a roof over their head. The essentials, food, clothing, and shelter shouldn't be, should be offered the day people get out. If we want to see this revolving door prison to stop, let's give people what their needs.
Absolutely. So thinking about that, many of the folks who are joining us are some people work in correctional institutions, but lots of people are supporting people when they leave prison. This is a question for everyone. What are the things that family physicians can do to better support transitional care or reintegration of people into the community upon release?
Well, I'm personally so grateful for the family physicians that are taking on these patients as they leave the correctional system. Some of them are repatriated to their family physician whom they've had prior to being incarcerated, which I think is such a precious thing to have that relationship and that continuity to go back to. And I'm so grateful when that happens. Other times we've had, even before the pandemic, we've had difficulties connecting very complex needs, multiple comorbidities, plus mental health, plus trauma, plus OAT treatment patients with brand new family physicians. This is a huge task for our healthcare team. Is one of their, on their list of things to do before someone is released, to be able to catch them and give them, a clinic who have committed to taking them on as a patient. And as someone who also work in the community myself, I can see how that could be a huge challenge where everyone is so, overly burdened by their existing clinical work, having to deal with the isolation, the access to services, not having the ability to see as many inpatient visits in a day just because of all the restrictions that we have to respect to be able to take on new patients, especially someone who's so complex. is admirable. And every day I'm floored by family physicians who are willing to say yes to this kind of request. And I thank you very much for that.
Anyone else have any other thoughts on what family physicians in the community can do?
Get us comfortable. Sorry, go ahead, Nader.
I just wanted to add, so the community transition teams that exist in BC, they have family physicians linked to them. So for the duration of time that somebody's out of custody, those teams will ensure that if there are any medical issues or addiction medicine issues, there is a physician available until they can be connected to a family physician. But my experience is that generally the family physicians are great at taking our patients into their care. It's just they're overwhelmed, and we have challenges finding people that have the space to do it.
Yeah, we run into the same problem. If there was one advice I might give, is get as comfortable as possible learning how to administer out. We still really struggle, even if it's just knowing where to transfer a person who's opioid addicted. But we've just started using Sublocade, the injectable buprenorphine, and we have a few folks that have started on it, and I've held it up because we can't find providers in the community. They'll have to be converted back to Suboxone when they leave. And if you can't, and I'm grateful when folks are willing to take it on. And it's quite complex, but even if the basics to help with the transition into treatment, into a treatment program, I think the more comfortable you are, the better. I mean, if somebody gave me $5 million tomorrow, I spend $4 million of it on substance abuse treatment.
Yeah, I think one of the biggest changes was when the province took over our healthcare system inside the prison. I mean, that's night and day. You know, the through care, you know, people having medication when they leave was huge, and same with their, you know, oat replacement. You know, and so that's been a huge benefit. You know, people having their medication, their supplies. So yeah, I remember when Alberta, I heard somebody speak out Alberta when Alberta had the province took over the healthcare. The biggest barrier is people not having ID or their medical number, or this big barrier for people coming out, right? So they can't just go to a walk-in clinic. Yeah, they can't go to a walk-in clinic. They can't do anything. So that's something we're really pushing for people to have their medical number before they leave.
Yeah.
Yeah, I agree. That has also been one of the challenges in Ontario as well, especially during the pandemic. It seems that the documentation requirement, there's some sort of slowdown in that process where OHIP card seems to be a barrier at this point when patients leave the institution. Thankfully, in the federal system, the medications that have already been prescribed while they are in the institution are funded once they are released. So even though I don't see them anymore, I will write a very long duration just so that they have a chance to access primary care and get to know someone, and who might at some point in the future be comfortable renewing them, but they've got a long runway to get there.
Yeah, as somebody in Ontario, I think like seeing and hearing some of the amazing work that's happening in healthcare systems where it is delivered by health and not corrections is sort of like, I'm a little bit envious, and also it's amazing and aspirational. Okay, so I think maybe we'll do one more question from our prearranged panel questions, and then we'll flip over to like Q&A from the group. So thinking about the broader public health pandemic response, how were prison populations accounted for or not accounted for in public health decision-making and initiatives? And I'll ask Nader to comment on this one first, and then Keith.
Oh, wonderful. Thank you for asking me first, Claire. All right. So basically, it's challenging because my experience in British Columbia with the pandemic is that the Ministry of Health basically tries to put the prison system within a category, and the only available categories were community health clinics, long-term care facilities, and hospitals. So a prison or a correctional center doesn't fit into any of those. So it's hard to fit it into that. So it took a little bit of time and a little bit of education, and thankfully, because BC Corrections Health was under the Provincial Health Services Authority, which is a sister agency within that agency is the BC CDC, we were able to access public health and very, very easily, and they learned very quickly the nature of congregate settings within prisons. So, but it is challenging, and I don't think we're there yet. I think there should be a specific category for prisons under health, so that we can do things and provide the best care we can to the people we look after.
Yeah, I agree, Nader. I think our experience, it's interesting because you come from one of the more liberal, I come from one of the more conservative provinces. Our experiences haven't been that different in the approach. I think even healthcare, even Alberta healthcare, didn't quite know where to place us, right? Are we a congregate living situation? Are we a nursing home situation? You know, and it wasn't until we started having these like massive outbreaks very rapidly. And it was exhausting to the system, particularly those doing contact tracing, that we started to kind of maybe inch up that ladder a little bit. And then there was the political aspect of, you know, where do you put inmates, you know, in the queue for treatment, right? And whereas we saw it as saving lives and keeping the spread from the community, because as I explained earlier, most of these people leave. It wasn't always seen that way. I will say overall it's gone well, because we've slowly worked very hard to move it up the ladder. But the concern I have with a separate category is I sometimes like being lumped in, because I think if you could just label the inmates, I'm afraid of us slipping down again. But I totally get your point.
Yeah, like how do we account for the unique considerations that prisons require while not furthering this like othering of people? Like often when I talk to people who don't work with people who are incarcerated, they're so surprised at how like people are part of our community and they're going in and out. And actually this is not like an other group. This is part of our community. On that note, what a great conversation. I'm so glad we've been able to chat. I want to have time for a couple of questions. So, Archana, do you want to take over the Q&A time that we've got?
Yeah, absolutely. So we have two great questions that have come up that I'm going to pose and open to the group. So one is essentially talking about how the focus in prisons has really been about COVID response, management, tracing, isolation, but there's a concern that that's happening at the expense of other health concerns and comorbidities of patients. And we saw about the opioid epidemic, the double epidemic happening, but also about mental health and taking care of patients' other needs. And I wonder if the panelists could speak to that and their own experience in terms of, you know, the focus on COVID at the expense of taking care of the whole person.
I'll try to answer that. It's a terrific question, and undoubtedly the resources needed to manage COVID within the institutions definitely affected programs, for example, and we talked about that earlier, and medical isolation, which can be confused with segregation, and so in BC Corrections, at least, we were trying to be very mindful of that, and so our isolation practices, in terms of the living units, was to have very small congregate cohorts of 4 to 5 people at a time, who would be a small bubble within themselves, and try to keep those separate. So in case someone was COVID positive within that small bubble, we could sort of contain it, and yet at the same time try not to keep people isolated from each other. And if somebody were to have COVID, then we would have to medically isolate them and provide education that this is in terms of making sure that we don't spread COVID around, but also ensure that they have time to come out and look after their needs and exercise and all that. But definitely it's a challenge, and I think a work in progress.
Yeah, I think much of programming came to a halt, and a lot of your programming is your substance abuse programming, your addictions programming, your mental health programming, the Indigenous programming. A lot of that stuff came because the staff needed to. It was an immediate versus it was an emergency versus long term, and the emergency was you had a lot of folks who were isolated and cohorted in very small groups. And staff were basically all staff were doing daily mental health checks, assessing to, not just COVID checks, but how are you doing in terms of your health care. So it absolutely took a hit, and it's not back yet, by a long shot, actually, at least for us.
And also for a lot of my federal clients who have to have so many courses and have to do all these programming to be able to get out on their day parole or their, full parole has all been put on halt because they can't do the programming. It's what they need to be released. So we have a lot more federal inmates who should be out in the community who aren't because all the programming stopped. So.
So, I mean, these are issues that are difficult to tackle, from a societal point of view. We're seeing an epidemic of mental health problems in our general population as well as the incarcerated population. On the individual level, though, I think each of us who are in the role of a caregiver, a clinician, it's really our job to see every person that we take care of and make that connection. I try and make a point, in every interaction that I have with my patients to both address the fact that, yes, there's a reality of the pandemic, but also that I'm here for all your other concerns as well, even, under layers of plastics and whatnot, that I have the space for you to discuss all of your health needs. And you can come back and see me every week if you need to, that kind of thing. And I think it means something on the individual level. And we're all capable of doing that, in your family medicine clinic or in the prison health clinic or, as a medical director of the institution. Our staff is suffering as well. It's not just the incarcerated patients. They're all very overworked, right? The whole isolation, daily checks, swabbing again and again. It's tiring. Our teams are quite burnt out, to be honest. It's one day at a time. I apologize for my puppy.
Thank you so much. The second question that we had raised was more of a specific question about shifts in providers in the system. So this question is specifically to Kingston. And the comment was that since the onset of COVID-19, there's been a shift where care previously was provided by contract family physicians or contract physicians, and they're now all the services are being provided by nurse practitioners, including regular primary care clinics, OAT clinics, after-hour call services. And I guess the question was really, is this just happening in Kingston? Is this happening across Ontario? Is this happening nationally? Has anyone seen this shift happening elsewhere, and are there any associated impacts?
I can talk. It's very difficult for us to get family physicians. There are times where I've advertised for over a year for our facilities, and we're talking about for 5 hours a week or less. and we don't get folks that will step up to the, we do use nurse practitioners. We're using more. I think those individuals who are quite well experienced, and this is true for MDs, by the way, it's the newbies, you know, that struggle, because it's a tough crowd sometimes. And you have to be a little thick-skinned around certain things. But I think individuals with experience and individuals who know their, you know, reach out to consult to colleagues. It hasn't been a significant difference, but a lot of our movement really has been because we don't have MDs that are willing to do it.
So at Grand Valley, the OAT contract is being renewed with an MP. Previously had been under a physician whose addiction medicine specialty. I mean, as a frontline clinician, I have no really any kind of input into that decision. So, you know, I imagine, I mean, clearly MPs are independent practitioners with their independent license. But I did go and get my OAT course done. I mean, in Ontario, since recently, one no longer requires a methadone license to be able to prescribe OAT or methadone. So there's not a barrier there. Anyone who's comfortable with the content area and skill set could do it. So I made sure that, you know, to be able to work with this person and that to have some understanding of the nuances and the complications to be able to support her or him in that role.
Great, thank you so much. And there was also a response by one of our attendees who said it's not happening across Ontario as they're an institutional MD. So it may just be a particular institution as opposed to a trend. And as Dr. Courtney was saying, just because frankly, it's probably very difficult to find family physicians that are willing to take on these positions in some contexts. Okay, so there is one last question, and the question is speaking about if prisoners are being, or if individuals in the prisons are being isolated, are the prison guards being regularly tested for COVID-19 as the cause of spread in the first place? So, you know, are those incarcerated being tested, or testing the individuals that are necessary, bringing in, like if we relate it to long-term care, there was a time in wave one where all the staff had to get periodically tested. Is that the same? Was that happening across prisons?
You can't mandate it in Alberta, at least. We offer it frequently. Whenever there's symptoms of any kind, we offer it, but it can't be mandated, and we have a significant number of people who choose not to.
It's offered weekly to all the staff members, including healthcare services at the GVI, and it's not mandatory, as Keith is saying.
And for British Columbia, the BC CDC and the Ministry of Health oversees testing strategy for COVID. So essentially, COVID testing is symptomatic. And if there's an outbreak, then they would do surveillance, but they wouldn't do surveillance randomly or regularly without a clinical indication.
Well, it's 8 p.m. in Ontario Eastern Time. I want to take this opportunity to open up the chat to just ask if anyone has any final comments, and then and it's okay if you don't, but if you want to say one final word, please feel free to, and then we'll end this session, which has been tremendous, and I think everyone would agree that we've learned a lot, and how we should learn from each other's provinces and what works in some scenarios and what we can learn from one another. All right, great. Thank you so much, everybody, for joining us. our panelists and to our attendees. I hope everyone has a great afternoon or evening wherever you are. Take care.
Thank you. Bye-bye, everyone.
Thank you.
Thanks for joining us, everyone.